On this episode of War Docs, we talk with retired U.S. Navy Captain Dr. Mike Malanoski, the Defense Health Agency Deputy Director. Dr. Malanoski provides his perspective on why the DHA was established in 2013, a history of the DHA, and an excellent summary of the current DHA strategy to stabilize and modernize the military health system. Dr. Malanoski served in our Navy for 30 years, retiring in 2011, and continues to serve Navy medicine in our MHS as our DHA Deputy Director. His over 40 years of service in key leadership positions is the background and experience military medicine needs during this pivotal time. Find out more about Dr. Malanoski and our previous guests on our website, wardocspodcast.com, and follow War Docs on your preferred podcast platform, and subscribe to our War Docs YouTube channel.
Welcome to War Docs, the military medicine podcast. This show brings you a first-hand, behind-the-scenes look into the mission, unique opportunities, and deployed experiences of the entire military healthcare team. From state-of-the-art hospitals in the United States to the most austere environments across the globe, War Docs has you covered.
Welcome to War Docs. I'm your host, Major General Retired Jeff Clark, and today we're privileged to have as our guest Navy Captain Retired Dr. Mike Malanoski. Mike, welcome to War Docs.
Oh, thank you, Jeff.
Yeah, thanks for being with us. Mike, I'm going to do a quick overview of your history so we can get to the questions about DHA strategy. You're not one to talk about yourself, so I'm going to talk about you just for a minute. So Dr. Malanoski went to Holy Cross on a Navy ROTC scholarship and then Georgetown School of Medicine on an HPSP scholarship. Went to Portsmouth Naval Hospital, did an internship in general surgery. After that, went and served on the USS Austin as their medical officer, returned to Portsmouth Naval Hospital as to finish his general surgery residency, and from there had myriad leadership positions as a general surgeon over departments, a clinician, operational assignments, and then with the Navy Bureau of Medicine and Surgery in the latter part of his career. Dr. Malanoski retired in 2011 after 3 decades of service, but then continued to serve as a civilian leader with Navy medicine and really with our military health system. From 2015 to 2022, Mike was the executive director for BUMED, a very senior position within Navy medicine, and led during a time of tremendous transformation highlighted by NDAA 17, which, as we all know, directed that Army, Navy, and Air Force MTFs would fall under the authority, direction, and control of the Defense Health Agency. So, Mike, you've had a remarkable career, and we're going to kind of pick it up from there. And again, thank you for being with us today. Mike, you started as a Defense Health Agency Deputy Director in 2022 and continue in that position. Can you give us an overview of your roles and responsibilities as the Deputy Director?
Yeah, I think, Jeff, most people are familiar with what a number 2 does in an organization, and so it depends on who the number 1 is as to what I actually do. In simple terms, I am responsible for ensuring that the DHA, both the headquarters and the enterprise, move in the direction that General Cross wants it to move. Internally, that means I work with the assistant directors. That's Brian Lyon for Assistant Director of Healthcare Administration, Rob Goodman, who is the 1-8, and Bob Hawkins, who is the 357, Don Johnson, who is Assistant Director for Support, and then the Chief of Staff, to get the enterprise aligned on where our strategy is going, and then to grease the wheels when they get stuck. Externally, I work at the level of the deputies, and so the DSG's Principal Deputy for Health Affairs, Ms. Mullen, and then across the department at about that level to ensure that when DHA needs to be represented, I can identify and share DHA position and then work to support where DHA supports, which is what we do. As a combat support agency and just in general, we are here to support the departments and the COCOMs in the execution of their mission.
Yeah, sounds like a full-time job. Mike, I've heard you point out a couple of times that context and background is important for understanding where we are today. As you know, the Defense Health Agency was established in October of 2013, 11 years ago. Could you, from your perspective, give us a brief overview of those 11 years, kind of how we've gotten to where we are now and kind of how DHA is postured?
Sure. And I think to start, it's important to understand the bigger picture. I think when we talk about systems, and the MHS is certainly a complex system, we talk about stable systems and unstable systems. And up until about 2010, I would say the MHS was a stable system. And when you are in a stable system and a stress is put on that system, it may wobble, it may shake, it may teeter, but it will usually come back to equilibrium over a period of time. And so if we look at 2010, what was the MHS as a system? We talk about the services and the services medical departments. I think we have to understand that in 2010, and this is a system that had worked for, we'll say, the past 25 to 30 years, certainly as long as I was in, each service had developed a medical department with an associated health system that supported that service. And so the medical assets were organized and had a mission set that was in alignment with the parent service. If you looked at the Air Force, it was organized around a wing construct, and it was basically mostly in garrison because that's where the Air Force deploys from. That's how the Air Force organizes. When you look at the Army, they align around their senior mission commander on a given installation. They have embedded medical, and then they have a close association with the MTF on that installation. And that MTF commander was also often double-hatted within the staff of that line command. And then when you look at the Navy organizes around their fleets. And so they're not actually installation-based. And you look at the MTFs and how the Navy organized their MTFs, they also had embedded medical. They also had units within the MTF that supported the fleet as a whole, not necessarily the installation or the port from which the MTF was at. So you could be at Portsmouth and you may be assigned to a ship that was in Mayport or was in Europe for that matter, if you were going to deploy. Again, the system was stable and it was an integrated system, an incredibly well integrated system. And that for some say seems odd because we talk about the challenges we have related to purchase care and direct care and the integration of those two systems, but that is not the integration I'm talking about. The system was integrated from the perspective of the MTF as it related to the service's mission set. And so there was an easy flow between the MTF and that service's operational forces in support of those operational forces. When the service needed something, it would reach into the MTF straight because it was all same chain of command and it executed. And so from that perspective, the system answered the mail on both mission sets. They did healthcare delivery and they did operational readiness support. So what happened? There was a stress applied to the system and it destabilized the system. And if you ask me what my opinion of what that stress was, it relates, because I spend most of my time in DC, it relates to money. And so around 2010, there was an increasing tightening of the dollars within the department. And for those who are old enough, from 2000 to 2010, it was actually a time of relative plenty for a lot of reasons. There was money to go around. But around 2010, that money dried up and the department started looking around for where there was money. And what they saw was the MHS. And at that time, it was about $55 billion. And the concern was that when people did project it out, the dollars were going to continue to escalate. And so the DepSecDef at the time, actually it was the SecDef, basically said if we don't get control of medical, it's going to eat our lunch. And so initially the department made a move and it established the DHA. And so the initial work was done in 2010, and then we were formally established in 2013. And it was, we were going to consolidate certain services to make the entire system more efficient. And so we talked about shared services, although if you understand shared services, these were not shared services, they were centralized services, but are related to pharmacy, resourcing, R&D, logistics. There was a list of about 10 that we were going to centralize within DHA and support all of the three systems with that. Then 2017 happened, and Congress said, we also agree that the system is too expensive for what it is giving us, and we are going to move the MTS underneath DHA. Now understand, and this is really important for those who are younger, the MTF was a military command that as part of its mission set did healthcare delivery. I cannot emphasize that enough. There was a dual mission set within the MTF, healthcare delivery and service medical support, which then the service supported the COCOM. So it was really that linkage that I talked about, and it was a military command. So it ran through C2. Congress, when you read that statute in 2017, said we are going to split the functions of the MTF. And we are going to give healthcare delivery to the DHA so it can be more efficient and effective. And we are going to give readiness, service-specific medical support to the services so the SGs can focus. So that would appear to make sense. Because it's tougher to focus on two things, just focus on one. What it failed to consider was how well integrated the system was as a system between the MTF and the services, and what it meant for it to be a military command, and how the department had identified how to meet two mission sets with one workforce. That, again, key piece. So when we look at healthcare systems, their cost structure is their personnel, their staff, because we are a service industry. Medical is a service industry. It's about people. And when you look at the staff of the MTFs, well, it varied between services, about 55%, give or take, is uniform. And so when you say we're going to split the mission set between DHA and services, in the civilian sector, elsewhere within the department, what you would say is, all right, then we have to split the assets. And the assets are the people. Didn't do that in 2017. Really have not done that up until 2024. And there are reasons for that, but it's an important thing to understand because it resulted in a tremendous amount of tension and a belief on one side or the other that they could function without that personnel piece. And so you now have a destabilized system. And to be honest, it is still destabilized. And we could talk a little bit about that, but I think it's important to now go to how we view systems. And because we're not computers, we need simplified models of a system to be able to work within it. That's called a paradigm. And so as long as the paradigm, the model in your head reflects what is in reality, and we won't get into a philosophical conversation about what reality is, but as long as the paradigm that you're using is close enough to reality, you will make decisions based on that paradigm and you don't even think about it. It is a given. It is like the sky is blue, water is cold. That's the way the world works. When you switch the environment so that the paradigm no longer applies, there is often a lag before people realize they have to shift paradigms. And so they will continue to make decisions based on the belief that gravity holds things down, as an example. That happened from 2017 to probably 2022 or 2023. And the reason for that is you would like to have done the transition in about a year and a half. We had COVID. We had changes in the approach is still the way we wanted to do it. And the long and the short of it is we didn't move all the people until 2022, when I would say it was finally completed. That's 2022. And the way that the department works is when the department identifies that there are efficiencies that could be had, I need to emphasize and underline, could be had, the department will program those efficiencies in with the hope, and I want to underline hope, that they will actually get the efficiencies. Now understand, we did a merger or an acquisition, you can look at it either way. And when you look at the private sector and mergers or acquisitions, about 15% of them will actually meet their targeted resourcing goals or their financial goals. 15%. That's the average. Our merger acquisition far more complicated than just two entities joining. So we had 3 health systems, and we already talked about it. Different cost structures, different mission sets, different cultures. And then on top of that, we took an organization, DHA, that had never managed MTFs or an enterprise like this before. It would be an understatement to say that the department was being overly optimistic and what they would expect to have happen if they said they were going to get savings within 1 or 2 years. Now you put COVID on top of that, you put inflation on top of that, and the long and the short of it is that the reason that we became unstable, which was the shortage of dollars in the present environment, got worse over time, and we couldn't even begin to do the work of trying to catch up until 2023. In 2022, senior leaders within medical said, we have a problem. And they did a study, and the study was done in about 6 weeks internal between the services and the DHA to say, why are all our numbers going in the wrong direction? Why aren't things working well? The long and the short of it is they identified that there was between $10 and $16 billion shortfall over the fit-up. As a side note to that, they also, for the first time, had numbers to demonstrate that purchased care was more expensive than direct care. And the reason for that is by unit cost, it is not. It's cheaper, but you have to factor in the fixed costs of the MTFs. So unless you totally close an MTF, that MTF has to run whether you push the care out or not. And so the department's strategy over the past 20 years had always been, when in doubt, push care to purchase care because it's cheaper. And so you can see we were accentuating the problem over time. And so when that study came out, and that was internal to the MHS, it was brought forward to senior department leadership. And as senior department leadership will often do, when a study is uncomfortable, is they want to confirm it. They did a larger study that confirmed it. And that was finished in 2023. That's the MHS Miser study. And that tells us that we still have a significant challenge related to resourcing against mission set within the MHS. DHA finally has all the assets on this side of the fence. General Places strategy, and I don't know that he ever put it on paper, but General Places strategy was to get the assets over as quickly as he could so that we could begin the work. And General Crossland has now begun the work to try and stabilize the system. Understanding that to stabilize the system, we have to move to an entirely different paradigm as to how we look at things. And that's an abbreviated version of how we got to where we are.
No, Mike, thanks for that. That was a very good overview and very pragmatic as you always are. So kind of tie back into that, I'm just going to read this for folks who aren't familiar. The DHA mission statement reads as follows. The Defense Health Agency supports our nation by improving health and building readiness, making extraordinary experiences ordinary and exceptional outcomes routine. The vision, unrelenting pursuit of excellence as we care for our joint force and those we are privileged to serve anytime, anywhere, always. You helped write that. Lieutenant General Toledo Crossland is the DHA director, has been in the position for a little over a year, January of 23. Chief Master Sergeant Tanya Johnson is the DHA senior enlisted leader. General Crossland and Chief Johnson, you and others developed a strategy within the realities that you just laid out. Could you give us just an overview of the strategy, kind of how it came to be, why it is what it is, and where we're going with that strategy?
Yeah, and it ties into what we started with where are we right now? And so we are in an unstable system. And the reason that we're in the unstable system still is we have not addressed the problem that started it all, which was the department. And you can say it's perception, you can say it's personal belief or group belief, but the department and our major stakeholders believed that the system was too expensive for what they were getting from it. And again, it isn't to say that we don't bring something worthwhile, but if we talk about value, and value is what you deliver over the cost, our value proposition was not accepted. It was decided by the department it was not good enough. And so what do we need to do to get to a stable place? We need to have where we have a mission set and the resources against that mission set that match. That's simple terms. How do we do that? When General Crossland came in, she believed two things. One, and fundamentally, when you have a situation where resources don't match mission set, and we often say that. We talk about the resources and we talk about the mission set. There are three pieces to the actual statement, and the last one we often don't say, but I'll say it. When your resources don't match mission set for the way that you do things, then you have three options. You can change the resources, increase the resources. You can decrease the mission set, which in our case would be decrease the footprint, or you can change the way you do business. And when you look at the strategy that General Crossland and the DHA has hit upon, it really tries to address all three of those things. Related to the resources, it has made a strong case to the department that the DHA and the DHP is underfunded at the present time for the mission set that it's being asked to do. And so over the past year to 2 years, and it will accelerate, we will put forward to the department with increasing fidelity, if you want this, it will cost that. And then the department will decide what it wants, but it will not have good numbers to say that's what it is. Senior leadership, I do believe, understands it at this point. We are also have a major focus on improving the management of the MHS. And so the reasons why we started in 2017 with efficiency and effectiveness, and that's the language from the statute, actually does make sense. There are things that across the three systems could be standardized because healthcare delivery is healthcare delivery. I need to emphasize that it is not a case of turning each MTF the same, because we've already talked, there's a dual mission set to that MTF still. It has to support the tenants on that installation or the parent service in some way, shape, or form. So there will be an element of an MTF that is specific to where it is and who it serves from an operational perspective. And then there is a more standardized healthcare delivery piece. And so that standardization of the healthcare delivery piece should make us a more efficient system. And that's, I'm using the true word of efficiency, which is not how the department usually uses it. And when the department says efficiency, they're talking about a wedge. They're talking about taking money. I'm talking about doing things in a simpler, more efficient way while still meeting mission set. So there are a slew of opportunities, whether it be in standardization of staffing and how we approach contracting and how we approach supplies and how we approach equipment buys. All of those things, we can find ways to do the same, paying less. Not having less, but paying less. Those efforts should get us on a better footing. It'll also demonstrate to the department that we can manage and that some of the challenges that we've had related to how the department views medical overall. So when we talk about the two major lines of effort in the strategy, that first line of effort, stabilization, is really addressing, one, how we manage, and two, getting the department to see that it has to make choices related to the direct care system. It has to decide what it wants and be willing to pay for that to ensure it gets good care. The second major line of effort related to the strategy is modernization. And this simply is, and again, my opinion, but I think it's the opinion of most, medical and medicine has changed dramatically, particularly over the past 5 to 7 years, and COVID accelerated those changes. And so you can talk about the commoditization of medicine, the customization of medicine. There's a whole lot of ways to talk about this, but it comes down to, across the industry, health systems are beginning to look at the patient as a customer who has choice. And so it is taken as a given by most of our patients that they're going to get good care. What they're looking for is how convenient it is, what the experience is in getting it. And so to be able for the MHS to deliver the same level of care as other health systems, and better, because I think we have advantages over other health systems, we need to move in that direction. And so fundamentally, in simple terms, we are presently a provider-centric fee-for-service system. And those things are intertwined, because if you're fee-for-service, then you're going to focus on the provider because that's who bills. And so you're going to drive the system to make the provider as efficient as you can. And we can get into why are we a fee-for-service when we don't really make a profit or we don't really bill the majority of our work. We'll put that aside. But that is the system that we have designed. That's what drives the system. Where we're going to move to is we're going to move to a patient-centric, value-based approach, capitated model. Patient-centric simply says you set up the system so that it is around the patient and the ability of the patient to maneuver easily through the system. That means the provider is often the last piece in the puzzle rather than the first piece in the puzzle as you look at how things go. As we move through that, we need to realize that data rules and the ability to leverage data and use data in all elements of what you do is going to be critical to being able to deliver the quality of medicine that the U.S., particularly in CONUS, expects. And that comes down to using that data for better clinical outcomes and also use that data for better patient experience. Use that data for better business efficiencies. And so a major piece of the effort and the line of effort is to increase our ability to leverage the data. And then finally, and I don't want to minimize this because it is a key piece to this, if we want our patients to be happy, we need our staff to be happy. There is plenty of literature out there that demonstrates there is a direct correlation between patient satisfaction and staff satisfaction. And that makes sense to anyone who has been in a clinic. If your front desk people aren't happy, that's the face of the clinic, and the patients will immediately come in with a good experience or a bad experience. And so we need to focus on how we can have our staff engaged, and we ensure that the staff are participating as we develop the processes that will drive the system rather than being told what they are. And so a lot of the work that we're doing now is at the 5 pilot sites where we're testing out these modernization approaches. And one of the major lifts there is how do we get it so that the staff have more input into how things are set up. That is not to say to make life easier. It is to say that they should have say in how they do things to get to the goals that we want. And I think we would all agree one of the strengths of the system is our staff, both our uniform and our civilians. And if we tell them where we want to go, they'll get us there. John Crossan has every belief in that. I have every belief in that. We just have to set them up so that they can execute, and they will. They will take care of our patients because our patients are our family. So that's the strategy in a nutshell.
Mike, thank you for that. as you know, I'm somewhat familiar with the strategy also. And I'm very optimistic. It is the way to go. Move away from fee-for-service, patient-centered, person-centered. Staff have a good system in which to work. It's just the way we must go. It's just the way we must go. And I thank you for your leadership. Related to that, in December of 23, Deputy Secretary of Defense, the Honorable Kathleen Hicks, issued a directive related to what you just talked about. The directive is stabilizing and improving the military health system, which is a great title, stabilizing and improving the military health system. And as you've laid out the DHA strategy on your leadership, General Crossland and Chief Johnson aligns with that. Could you give us an overview of that directive, kind of how it came to be, kind of what was the premise behind it, and what it is in fact directing?
Yeah, and always have to be careful. So now we'll get into Mike Malanoski's opinion and analysis as opposed to DHA's. And so this is Mike Malanoski's view of how we got to where we are, and why DepSecDef put out that memo, and why I think it is important. And we'll go back to where we started, which is we had a system that had a labor pool, the uniforms, that were basically shared in mission set, but had a single command structure. So when that split occurred in 2017, related to the uniforms stayed with the service, and then they worked in the MTS. There were a lot of factors that came into play at about that point in time. There were some moves made by the services at a higher level as to what the top line in medical would be. And so medical, they were going to cut significantly the number of medical billets. And again, that's a topic for another discussion. But the important thing is that those numbers were going to go down significantly, and the service were starting to position themselves to that. That affected pipelines, and then you had COVID on top of that, and then you had the hiring frenzy in the public sector because the economy really had taken off. And so the long and the short of it was, not just within medical, but within the services, there was a significant drop in the number of medical available. Because of that, the services, particularly the Navy and the Army, prioritized their fills. And the prioritization is pretty similar. First, you fill operational billets, and then you fill overseas billets, and then you fill CONUS billets. And then within CONUS, you have a set of priorities. It's important then to understand, if we have a drop in the overall top line, then where is that drop going to be felt the most? It's going to be felt in the MTS. So now you have a problem with uniform staffing. Now, when you then add what we just talked about, which is COVID followed by inflation, you have a situation where, from the civilian perspective, and our civilians, we had a tough time competing. The labor pool was much smaller, and the money that was being tossed around in the private sector was significantly higher than what the MHS could offer. Even within the federal government, when you compare the VA with what we could do in DoD, there was a significant difference there. And so when you talk about destabilization of an organization that is dependent on people, the easiest way to destabilize it is to take the people away. And so what the DepSecDef memo really is trying to do is to say, to stabilize the system, we need to stabilize the workforce. To be able to stabilize the workforce, we need to address both the our civilians in our contracts and how we approach that, and then how we approach using the military. The biggest piece related to the military is to have transparency across the department and how they're being used. And so I need to underline this. The reason that we have medical personnel in uniform is to support the operational mission. That is military essential. That is what uniforms are for. And so DHA is never going to say if a service or a COCOM needs medical support, we're not going to send it, or it should be with us rather than them. Upfront, need everyone to understand that because messages get the way they get. With that said, the department needs to understand what risk it assumes as it uses those medical assets. And so from the DHA's perspective, and therefore the department's perspective, if you don't put uniforms in DHA billets, the department will end up with a bill because the benefit is must pay. And you can say, well, that's okay because that's not our mission to make money. But here's the thing. Medical is a must pay bill. And so from the department's perspective, if they have to pay medical because there's a gap there, then they are not going to be able to buy planes and missiles and tanks and people. So it is important for the department to understand what risk they're assuming when those billets aren't filled. By the same token, if the department says, well, we don't want to take that financial risk because it impacts our ability with the warfighter and the support, but then you're going to take medical away from the warfighter, the department needs to understand what risk they are taking on that side. And that's what we didn't have before. We didn't have transparency and the ability to see across the system. So department leadership, and now we're talking SecDef, DepSecDef, PNR, the unders, the chiefs, they need to be able to see it, and then they need to make a call as to what is best from the department's mission as to where they align medical. And so that's what the DepSecDef memo does. I mean, there's a lot of language in there about assign, and there is language in there about how the assets are deployed and shifting of resources, but fundamentally related to the uniform side of the house, it really is, we are going to be transparent about where the uniforms are, and then we're going to be able to put to senior leadership the risks on both sides, and senior leadership will then determine where they want to take the risk. That's what it did for the uniform side. Related to the civilian side, there are pieces that we are acting on now to improve our ability to be competitive in that area. And so moving to Title 38, which type of program, which that's what the VA has. It gives you a little bit more leeway in what you offer in clinical specialties. We'll move to that initially with the nurses, and then over time to the support staff, and then to the entirety of medical. That'll probably take between 2 and 5 years. There are some other simple things that we're doing related to improving hiring times overall. And then again, it comes down to how much we are resourced against as to where we go. And so when you look at that memo, it really, just to bring it all back full circle, it really is about, when they say stabilization of the system is based on people. It's how do we get a more stable workforce to be able to meet mission set.
Yeah, Mike, thank you for that. There's also an element of it about bringing volume and complexity of care back into the MTF so that when the uniforms are working in the MTFs, they can emphasize ready medical force. There's also an element of that. Is that your understanding also?
Yeah, yes, and that's state, and the intent is, and the reason they have to stabilize the workforce is to be able to meet that dual mission, which is healthcare delivery and readiness. And so there is an understanding that the purpose of the direct care system at the end of the day is readiness. If it was just about healthcare delivery, in a lot of places, we don't really need that. We could do it just like every other federal employee does. We could get a health plan. And so we need to have facilities so that our people can maintain currency from a medical perspective. We also need to have facilities in certain locations because the civilian sector doesn't provide the health care at the convenience or geographic proximity so that those line units can do their mission set. And so I say this all the time, think most of where the Air Force is and much of where the Army is. It's not exactly a metropolitan area. Now, the Navy does not have that problem as much because the Navy hangs around beaches and big cities. But still, there is that element. There's 29 Palms, there's other locations where, from a medically ready force, you need to have medical there if you want that force to be optimized. That will be an interesting element of how this all moves forward, because we've talked about we need to balance our footprint with the resources we're giving. And so when you look at the system, you have your med-sends in your big locations, and then you have your isolated locations. And if you are going to optimize a ready medical force, you're going to want your assets in your bigger locations. If you want to optimize the cost of healthcare delivery, you're going to want your assets in the bigger locations because that's where you can recapture care. If you want to optimize a medically ready force, you're going to want your assets in the smaller locations because they can't get medical from the network. And so this is why I believe that transparency that the DepSec memo will give will allow department leadership to understand, and they will have to make the decision as to what that balance point is. And that needs to really be decided. That's not a DHA decision. We need to be told what it is so that we can work towards that. But the department, the services will decide what they want. And then we will say, if you want that, it costs this much. And then we are expected to deliver what we said we're going to deliver. But I do think that piece related to recapture is important for the stabilization from two perspectives. We've already talked about the money piece, and then the ability to ensure we can meet the readiness mission. Our people are ready to go. We need workload. They need to see patients. And the system has gotten smaller and smaller, and we talked about why that is, because there was a push towards purchase care whenever there was a shortage of money. And so we need to bring the system back to the size it needs to be able to meet both patients.
Yeah, Mike, thank you for that. That's an excellent rundown and much appreciated. I'm going to starting to close up here. I'm going to let you, anything else you'd like to share with the audience before we wrap up?
Yeah, and I think it comes back to paradigms and how we view the world and the challenges you can get into when you don't realize that the environment has changed. And so particularly there is a lag sometimes between what the field sees and what actually happens at headquarters. And where there's been an environmental change and how it impacts the field because of that lag, they will often attribute the problem to something that isn't a problem anymore. And I'll get to the point here. From 2017, we'll say to 2019, there was not happiness between the services and DHA. And I'm being generous there. There was, I don't want to say contempt, that's too strong a word. I don't believe there was respect for what each other did and how well they did it and the challenges each had in their lanes. And so for that entire time, when senior department leadership asked medical what the problem was, if they went to the services said, well, it's obvious what the problem is. DHA doesn't know what it's doing. And if senior department leadership went to DHA and asked them what the problem was, DHA would say, well, it's obvious. The services are not supporting. If you just step back and realize that then means from senior department's leadership, their takeaway is much like if they were Solomon, and often I feel they are Solomon, but they're looking at the situation and they're saying, oh, I know the problem. The services and DHA aren't getting along. And so if they get along, the problem is solved. Now, hopefully if people have been listening to even a little bit of what I talked about, they understand that wasn't the problem. That accentuated the problem. It took us longer to try and address the problem, but the problem fundamentally is the resources didn't match the mission set. And so as we move forward, people realizing that it is not a question of the services or DHA not getting along. I can tell you at headquarters, I respect, mostly because I came from there 2 years ago. I respect what the services do. I understand the challenges they have, and they have as big a challenges as DHA does on their side of the house, because again, we're talking about a limited amount of assets to do a certain mission set. And so they feel the same pressures we do. And I do believe that that does services, and certainly the DSGs that I work with respect what DHA is trying to do and understands the challenges that we have. That doesn't mean that the problems don't exist. So I guess point one is understand where we really are and what the real challenges are. And number two, there is still, and I think it is good that each service has their own culture, but there is a tendency to believe that DHA has to be one of the three. And I can tell you, DHA is not one of the three. I think we are still developing what our culture is, but there is a perception, depending on where you sit, that we lean heavily towards one service or towards the other. And so then it becomes, we are not working as a team. We are not seeing the problem. If only DHA was more fair in how they allocated resources, then we would have enough. Again, hopefully people have heard what the problem is. Not enough resources. It's not a case where we have some MTFs that are living in a land of plenty and other MTFs that are way short. Everyone is short across the system. There are some that are more short than others. There's no question about that. But it's not because of a choice. It's because of a multitude of factors as we learn how to better manage the system. So again, I think focusing on the problem and understanding that it is not what it was 5 years ago or even 4 years ago, I think it'll help everybody move forward. And then finally, I think we have to acknowledge that we are all a bit fatigued. Change is always hard. Change takes a lot out of people. And we've just described, we have started in 2017 and we have not come near to completion on the major change effort. And so we are still having to work through that. And until we get to that endpoint where we have a stable system and people understand the system, it is going to wear and gnaw on people. I do think that we're going to get there. I think we're going to probably get there in the next 12 to 24 months where things are going to solidify. The services will know their role, DHA will know their role, and the department will be able to tell us this is what we're going to be. I think that will be the endpoint we're looking for. But I know how hard it is when people have told you just a little bit longer and it'll be there, a little bit longer. I mean, we've all been on that car ride. And after a while, we just stop listening to mom and dad. And we assume we're never going to get there. We're going to get there. I really believe that. But from our perspective, we understand how hard it has been and how hard it continues to be for those in the field. And we are trying to get there as fast as we can. So I will ask for a little more patience for those who are listening who are working in MTFs or training commands or the labs. I think that's all I would add, Jeff.
That was great. I've heard there are pragmatists and there are optimists. It's better to be a pragmatist and just embrace reality, but realize there's good people that care deeply that are working hard like you and General Crossland and the SGs and so forth. And so I'm optimistic also. I appreciate your time today. And so our guest today has been Dr. Mike Malanoski, Defense Health Agency Deputy Director. Mike, we appreciate your leadership. We appreciate your time, and we thank you for your 4 decades of continuing service to our nation. May God bless.
Thanks a lot, Jeff.
Thank you for listening to War Docs. We sure hope you enjoyed it. War Docs is a nonprofit organization supported by donations from listeners like you. Please follow and subscribe to our show on whatever platform you consume your podcasts, and rate and review this episode, and share the show with your contacts on social media. Find out more information about our show, our guests, and how to become a member of Team War Docs on wardocspodcast.com. Thank you for your support. If you like war stories and medical drama, War Docs has you covered. Spread the word.